For a conversation on confronting America's opioid epidemic, please welcome Dr. Lipi Roy, Clinical Assistant Professor at NYU Langone Health, Dr. John F. Kelly, Associate Professor at Harvard Medical School and Director of the Recovery Research Institute at Mass Gen, and Kassandra Frederique, New York State Director of the Drug Policy Alliance. Back to lead the conversation is the Atlantic's Ross Andersen.
All right, before we get started with another conversation about opioids today, I wanted to kind of tick through a few statistics that really demonstrate how bad this problem is. The first, as you can see up there, 45 states saw a 30% increase in opioid overdoses from July 2016 to September 2017. The Midwest witnessed a 70% increase in opioid overdoses in that same period. And opioid overdoses in large cities increased by 54%. To start us off today, I wanted to ask all three of you, first of all, whether you would agree with the sentiment that this problem is getting worse, not better, and why.
Well,
Lipi,
I'm
jump right in.
Happy to start. But before I start, I just want to say I'm thrilled to be back in Boston, where I lived for 5 years. I was a primary care doctor to Boston's homeless men and women. And I also want to say congratulations to the Boston Bruins for a great season. The playoffs are starting this Thursday. And this is where I'm going to lose the audience, because I'm going to say I'm actually cheering for the Toronto Maple Leafs. I'm sorry, because I'm born and raised in Toronto. I also want to just give a significant shout out, though, to the state of Massachusetts, which has really been leading the charge in addressing the opioid epidemic. Since 2014, when then Governor Deval Patrick declared the opioid epidemic a public health emergency, since that time, Governor Charlie Baker, to Attorney General Maura Healey, who you heard from this morning, to Boston's Mayor Marty Walsh, who's been very open about his own recovery from alcohol. You need people in leadership positions openly discussing this to destigmatize and get people the treatment that they need. And Ross, to answer your question, unfortunately, it's really not getting better. Not only are we not seeing death rates decline, we're not really seeing a plateau either. Having said that, in fact, rates are rising. But I will say, I believe a study came out showing that opioid overdose death rates in Massachusetts did decline last year, and that's the first time in years. And I think that's a result of aggressive intervention approaches in Massachusetts.
Yeah, and thank you. Thanks for the topic, for having this topic here. Is it getting worse? Certainly, if you look at overdoses in certain pockets of the country, we're seeing still big increases in overdose deaths from opioids, as well as other drugs also, but particularly opioids. Some things are getting better in terms of the focus, the national attention is getting better. It's unfortunately very late to the party in terms of addressing it, a little bit too little, too late. I still think that this should have more national resources devoted to it to address it properly. So making progress, but is it getting worse? Yes.
Yeah, and I would say, obviously, the rates of overdose deaths are definitely increasing, but what I will say is that the conversation around it has definitely improved in some cases. I think you're seeing people really focus on things that are helpful, like stigma. In the way that we talk about the overdose crisis, I think you're seeing people have conversations about what public education looks like and really focusing on saving lives as opposed to things that we've done in the past, which focuses on criminalization. So I would say that there are some lessons that we are learning, obviously based on the conversation that we're hearing out of the federal government. Some people continue to use the same rule book that has been wrong for the last 50 years. But I think there's a conversation here that some people know what can save lives, and that's what's most encouraging about this moment.
John, I want to ask you, I know some of your research is about the biological underpinnings of addiction. And do we have a more granular picture now as to what role genetics plays or like, neurophysiology, or as opposed to background conditions in someone's life?
Mm-hmm. Yeah, well, we've known for actually quite a long time about the genetic contribution to addiction in general. So roughly half the risk for addiction is conferred by our genetics, between 40 and 60% of the risk. So when you think about it, when we think about stigma and discrimination and cause and controllability of substance use disorders, opioid use disorder in particular, there are just like many other illnesses from which we might suffer throughout the life course, addiction is one of those that is contributed to by our genetics and biology as well as environment. So it's not just genetics. It's not genetically determined, but it's genetically influenced to a large degree. So when we think about stigma and cause and controllability, and we know that opioid addiction in particular, of all the different types of substance use disorders that one can suffer from, opioids tends to, and heroin in particular, tends to be the most stigmatized, not just in the US, but internationally as well. And part of that stigmatization has to do with a lack of understanding about the nature of these disorders. The fact that they are, gene by environment interactions, they are complex conditions, but genetics play an important role in regards to how people who are exposed, how they initially respond. So if you take a common drug like alcohol, only about 15% of the population, the majority of the population, is exposed to alcohol, which is a potent reinforcing drug. It's psychoactive. People become addicted to it, but only about 15% of people who are exposed become addicted. Now, why is that? It's because, in part, of the initial experience that people have on that initial exposure. Some people don't care for it at all. Some people can take it or leave it, and some people will actually consume enough they'll poison themselves to death roughly 30 to 40 years prior to Mother Nature intended. So there's some kind of medical malfunction that goes on as a result of this interaction between genes and exposure, which leads to repetition. The repetition of exposure changes the brain, and this brain change we call addiction. It results in these brain changes, structural and functional changes, which leads to repeated administration and can lead to overdose death.
What's the, I'm sorry, I missed the difference. So with alcohol, 15%, and then with opioids, do we know what the percentages for them?
It's about 20 to 25%.
20 to 25, sorry. Kassandra, I want to ask you, you mentioned briefly the federal government and that they are looking at this problem with an outdated perspective. I know that in the Drug Policy Alliance in New York, you interfaced with the New York legislator a great deal. How receptive have they been to what you would regard as kind of the forward-looking approach to this?
So what's been really interesting in dealing with elected officials around the overdose crisis is just how much people are being, how much elected officials can't afford to use the old playbook, because their constituents are consistently coming into their offices and telling them about their moms and their brothers and their friends that have lost their lives. And the things that they have said before, which is don't do drugs or lock them up, I don't know if that's going to work still.
Okay. Yeah. There, if you don't
mind.
My
ears are abnormally small.
There you go.
Don't work. And the things that they know, one of the things that you're consistently seeing elected officials say right now is we can't arrest our way out of the opioid crisis. Right? We can't arrest our way out of this. We have to find a new way, which is, as someone who is someone from New York City, I don't really like the Bruins or the Patriots or anything else. It is incredibly hurtful, right? Because we have decided to look at drug crises in the past and decide that the criminal justice system was the way to deal with someone else's addiction. That is very different than what we're experiencing in legislatures across the country. There are still a lot of people that are continued that think that just say no and lock them up and throw away the key is effective. But there are more people that are having conversations about how can we have different perspectives. And harm reduction, which is the public, which is what we focus on, things like syringe exchange or medication-assisted treatment like methadone and buprenorphine, are things that people are more receptive to right now. We still have a very long way to go when it comes to elected officials, but most of that is because elected officials don't lead the parade. People that use drugs, people that experience loss, they lead the parade. And so part of our job is really to inform the mass public in order to guide the way that legislatures act. And so we see that a lot in New York when we're having conversations about safer consumption spaces, where the public is pushing elected officials to act and to be bold and be innovative and focus on interventions that are actually based in science as opposed to outdated moral and puritanical ideals.
Yeah. Lipi, you were had what I can only imagine was an extraordinary experience. You were the chief of addiction medicine for New York State's jails, including Rikers. What did you learn about addiction in that context, and how have you been able to sort of apply it here in the outside world?
Yeah, and thank you for asking that question. Let me just premise everything that I'm talking about today. You know, I get touted as an addiction expert, but I'll be very blunt and honest. Everything I talk about today, I've learned from on-the-job training, on-the-job learning, meeting people, like incredible experts like that are on this panel. I never learned any of this during medical school or during my residency training, and I went to some good institutions. I think at the addiction community, we're really trying to change that in terms of really getting medical schools and training programs to incorporate more curricula focused on pain management and on addiction. But let me tell you, so everything I knew about Rikers, however, I learned from watching Law and Order. And let me tell you, there's no DA Jack McCoy there. On a really serious note, it is a traumatizing experience to be incarcerated, and Rikers is no exception. And again, this is an area that, say, Kassandra and the DPA know very, very well. So let me just share a few data points. Over 50% of the men and women that are behind bars at Rikers experience some type of substance use disorder. And from 2011 to 2016, about 30,000 people were diagnosed with an active opioid use disorder. As Kassandra pointed out, we cannot arrest our way out of this. And frankly, the opioid epidemic and really addiction in general, it's a public health issue. It's a medical issue. It is not a criminal justice issue. And again, there are police departments really throughout the country, including here in Gloucester, Massachusetts, and other places where they're really, really appreciating and embracing that. So instead of arresting and then incarcerating people, they're connecting them to care, to a substance use counselor, whatnot. But yeah, it's, you know, I met a lot of men and women that are behind bars, you know, prescribed the methadone, buprenorphine. Look, I don't want anyone to ever have to be behind bars at Rikers Island, but should you happen to have an opioid use issue and happen to get incarcerated, let it be Rikers, because it's one of the few correctional institutions in all of the United States that offers evidence-based treatment for your opioid use disorder. Specifically, they've been prescribing methadone since 1960s, 67, I believe, and starting in 2015, they started prescribing buprenorphine. But any other detention center in the country, you will be struggling with opioid withdrawal, uncomfortable opioid withdrawal symptoms on your own, which, by the way, is a human rights violation. If you had diabetes and get arrested, they're not going to stop you from getting your insulin. If you have leukemia, you'll get your chemotherapy. But God forbid should you have an addiction to alcohol, opioids. And let me just point out, I'm so glad that John was talking about alcohol. You know, I understand that we're focusing on opioids as we should because people are actively, acutely dying right now, but alcohol kills far more people than opioids, and cigarettes kill far more people than opioids and alcohol combined. So I'm glad at least this, the attention on opioids is shining a bigger, broader spotlight on addiction in general, which really has not been addressed. People have not been addressing people with addiction that much at all, frankly, and it's because of what Kassandra mentioned, which is stigma, profound stigma, which is acting as a barrier to care to people with addiction.
One of the more successful interventions, at least at the research level, that has been recently proposed is the idea of safe injection sites where addicts can go and not fear being arrested and possibly be ushered into treatment, or they have overdose medication on hand. I'm sure I'm missing some aspect of these sites. But one of our reporters who actually was just on stage, Olga Kazan, who was just in Vancouver and then in Seattle, where they're trying to put one, and meeting fierce political resistance. And so I want for you three who are looking at this issue kind of on a daily basis, how successful are you being in pushing that idea out to people that this is something that we need in our communities sooner rather than later?
Yeah, let me just add, I think with harm reduction, it's, again, not something I ever learned in medical school or in training, but I've come to learn that it is critical in saving patients' lives and at least improving the quality of their life. So harm reduction strategies have been used for decades, really, in terms of condoms, needle exchange, and naloxone for opioids. But yeah, safe consumption sites, safe injection facilities. I applaud Vancouver's Insight program, which started in 2003. And by the way, that didn't happen overnight. That took tremendous effort for years. But now, fast forward, if you look at their data, you can't argue with the data, which shows that they have profound reduction in HIV and Hep C transmission, reduction in overdose incidents, reduction in overdose deaths, decrease in drug-related crime, and absolutely zero fatalities. So I'm a strong proponent, and I'd love to hear what you guys think as well.
Yeah, I agree. I mean, I think the preliminary data that we have on these safe injection facilities look very promising. I think intuitively they make sense. If you're working in the field, I can see how people, if you weren't involved and understand the nuances of addiction and how, first and foremost, you have to keep people, you can't treat dead people. You have to make sure that they stay alive. We know needle exchanges increase the rates of engagement with treatment because people come in, they get clean needles, et cetera. And the same is true of safe injection facilities. Not only public health, but public safety, because you get reductions in discarded needles around those areas, which tend to be a lot of homeless areas. That's where they tend to be located. So public health and public safety are enhanced by these sites. But I can see why there's opposition, because at first glance, if you didn't understand the nuances, that you might think, how could that work? Isn't that going to increase use, right? This is what the normal reaction would be. This would you'd encourage use, right? But in fact, when you look at the data and look at the nuances of it, actually decreases use, keeps people alive, gives them a chance to get into recovery.
Yeah.
And I would say, I think something that's super important for people to recognize is that safer consumption spaces are not new. They are new to the United States, but they're over 30 years in being existing in the world. So these are facilities that have 30 years of research behind them. The other thing that I would say is, I think it's super important for people to realize that this is not our first health crisis. When we're talking about health crises, like HIV/AIDS, one of the biggest and most successful health interventions that happened were syringe exchanges, where people could get clean needles, right, from health providers. And that single-handedly demolished the transmission of HIV and AIDS and Hep C amongst people that use drugs. We have the research and understanding that public health interventions that center people that use drugs can work and do work. The conversation around safer injection facilities really is about whether we want to save lives, yes or no. If we want to save lives, then we have to have safer consumption spaces. I'm leading the campaign with various groups in New York City and following Mayor de Blasio all over the city because he promised us a feasibility report that was supposed to come out in 2016 in November. It is now April 2018. And he, last February, he was saying, soon, it's coming out soon on February 5th. Since that day, 236 people have died in New York City. So the conversation for me is not whether or not we should do this intervention based on if an elected official is comfortable. It is whether I think it's important enough for my friends and family that struggle with addiction, are they worthy of a Tuesday? Are they worthy of a Wednesday? Are they worthy of a Thursday? If that answer is yes, then we need to expedite the conversation and actually cite these places where we can have conversations about move from having conversations and actually saving people's lives, because that's what safer consumption spaces do.
I want to open it up to our large audience here in case there are any questions. Looks like there's no one else. Somebody.
My name's Jordan. I'm a patient and a blogger. And I guess it's not a question as much as a comment. I'm a chronic pain patient, and as a result of the response to the opioid epidemic, I've been feeling attacked, and I know many other pain patients are too. It feels like there's a war against us, and many of us are very, very nervous that we're going to lose access to our medication. What would you say to that?
I would say you're absolutely right. There is a war on chronic pain patients, and there's a war on people that use drugs, and there's a war on people in recovery. The way that the United States has set up our conversation on how to manage drugs is an illusion. Prohibition, making drugs illegal, is the illusion of control. If we're going to have a conversation about how to manage drugs, then we need to center the people that are using the drugs. Chronic pain patients, even in this opioid overdose crisis, should not be fearful of talking to their doctors. Their doctors should not be adjusting their treatment plans based on the hysteria that's happening out there. There are a lot of people dying. And the ways that we are having conversations about taking medication away from chronic pain patients is not going to save more lives. It's actually going to put more people in harm's way. And so honestly, if we are truly considerate about people's pains, people's experiences, and their lives, then we need to have a real conversation about decriminalizing drugs and regulating drugs in a way that makes sense for the people most impacted.
Let me just also add that I am concerned that the pendulum is swinging too far the other direction. So patients in whom opioids are clinically indicated are being deprived, and rather abruptly, because many doctors are getting this message, oh, opioids are bad, stop, 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 and they're cutting off their medications. It's inappropriate, and we're really trying to change that. And again, as I said before, most doctors really don't get trained on pain management and what's really appropriate. So we're trying to fix that.
I think we've got time for one more.
That was convenient, right? Yeah. Hi, Scott Rabchuk from Hill Holiday. One of the things that there's a place here in Boston called Boston Healthcare for the Homeless, and they have not a safe injection site, but they have a place for recovery. It's called the Safe Place for Observation and Treatment. SPOT, yes, exactly. So they've had quite a success there in terms of what you said, keeping people alive. Their biggest challenge is to get people into treatment and recovery, because there's such a paucity of available spaces, the compensation aspect or the reimbursement aspect. Where are you guys seeing shed spotlights for that or encouragement in terms of recovery and treatment? So
I'm really glad you raised that point. So let me just cite that of the 23 million Americans with substance use disorder, only 10% access treatment. So and the major barrier is stigma, the major barrier to treatment. Can you imagine if only 10% of my high blood pressure patients got treatment? That means the other 90% will be getting blind, liver failure, kidney failure, and dying of strokes and heart attacks. And by the way, I'd probably lose my medical license. But the 10% that are getting addiction treatment, we seem to be okay with that, and that's unacceptable. We need to really reduce the stigma, what John and Kassandra were talking about, and by doing so by changing our vocabulary, using words like substance use disorder, not substance abuser or drug abuser. Let's get rid of the war on drugs and other punitive, tough language. And don't say dirty urine. Your urine is positive. So language like that, because it matters. And then also, we really need to expand access to life-saving medications like buprenorphine or Suboxone, Subutex, and methadone, and more recently naltrexone. These are medications that save lives. They do not substitute one addiction for another, because this is pushback that I get all the time. So these are things that we need to do. And yeah, we need to absolutely increase the number of recovery beds, residential treatment beds, get more substance use counselors, case managers. We need to do a lot more of that. And I'm hoping that more federal dollars will go towards treatment beds and services.
I think part of it too is to make sure that we integrate addiction care as part of medicine, mainstream medicine, instead of providing grants, specific grants for the care of substance use disorders. Why don't we pay for it just the same as we would pay for any other medical condition.
I would also say I think what's super important is that oftentimes when people talk about treatment, they're only talking about one specific modality. So people are only talking about abstinence-based treatment. And so I think it's super, and then if you're only talking about abstinence-based treatment, then for some people, the eligibility requirements to even access certain programs serve as a barrier for someone who has made the decision that they want to stop using today or they want to try today. And I think we really need to get to a place where treatment facilities are actually focused on more low threshold maintenance, on getting people inside of the door, as opposed to making people jump through multiple hoops to get the kind of treatment that they need. As someone who struggles with her weight, if I had to pass certain tests in order to access a Weight Watcher meeting, I would never get there. Right? So like, because I eat pizza before I go. So but that's essentially what we're asking people that struggle with addiction to do. And so if people have made the decision on Monday that they need treatment, they shouldn't have to jump through multiple hoops to access that treatment on Monday. Treatment delayed is treatment denied, and treatment denied means someone dies.
Yep.
And that's how we have to put the spectrum in the way that we talk about giving people access to treatment.
Yep.
Lipi, John, Kassandra, this has been really great. Thanks for coming this afternoon.